Hi, dentist again. This is Mohammed Musa from AFK Study Plan. So let's move on to pediatric restorative dentistry. Before we speak about the diagnosis for trauma and for primary tooth and how to deal with it, you can go to the previous video to check this part. And now we're gonna, and in this last article, we speak about something called pulpotomy, partial pulpotomy. So here we're gonna speak about restorative dentistry as a whole, what we're gonna do with a primary tooth, and what we're gonna do with immature permanent tooth, and the rationale how to deal with this. And this is, as we mentioned before, extremely important. And you might find some question that you are maybe confused with the concept about the question after reading this article and following this and getting your notes under the question which will appear in your screen now. I think you will be good, and feel free to share this video and give your notes and give me your feedback. Okay? With that all said, let's dig deep in this article. Okay, so before we start, there is some terminology that need to be very familiar with, like dental caries, intercoronal restoration, restorative treatment, caries diagnosis. But there is some short, like style C crown is SSC, pre-formed metal crown is PMC, randomized clinical trials is RCT. And then while we're going forward, I will try to explain this. Okay, they are trying to be sophisticated. Okay, anyway. Okay, so management of dental caries was based on the belief that caries was a progressive disease that eventually destroyed the tooth unless was a surgical or restorative intervention. And now we are trying to think about it in a different way. Contemporary management of dental caries include identification of individual risk for caries progression, understanding understanding of the disease process for the individual, and active surveillance to assess disease progression. What does this mean? It means like not every caries inside the enamel will be restored for every patient. So you cannot look at X-ray, oh, I will restore this one. No, you should know the caries risk for this patient, his regimen for oral hygiene, his frequency of coming to the office, his diet, his fluoride intake. It's a lot of factors. It's not like looking in X-ray or looking to a cavity and say, okay, I will restore this one. Okay, I will use SDF for this one. No, it's like a multifactorial, and this will be explained more in the article explaining about the new caries classification ICCMS. And now we are just speaking about the restoration and when to restore and how to restore and which material to be restored. So, when to restore? Among the objectives of restorative treatment are to repair or limit the damage from caries, protect and preserve the tooth. So, we should aim for a vital bulb therapy in primary teeth with deep caries lesion and bulb therapy for primary and immature permanent teeth. Meaning, like as we mentioned in the previous articles, bulb vitality is extremely important. Maintain bulbal vitality, especially in immature permanent tooth for continued exogenesis, meaning like we should aim to preserve bulb vitality. Why? Because we need this tooth to complete the root development. We need this permanent tooth, lower six, the beautiful lower six, not to be short and be has external resorption and very short and weak, and then you need to take it out. So we should aim for this, but it's not indicated for every tooth. Not every tooth we can say, okay, let's do pulpotomy or do partial pulpotomy. You should have clinical pictures. You should have some signs and symptoms that indicate, okay, this tooth is indicated for vital tooth therapy. Primary teeth may be more susceptible to restoration failures than permanent teeth. Why? Before restoration of primary tooth, one need to consider the length of time until tooth exfoliation. Meaning, like before you go and you see lower D or lower E has a big cavity and you say, okay, let's restore it. Let's do pulpotomy, let's do pulpectomy. You should know the caries progression. You should know when the permanent tooth is coming. You should know the vital signs of this tooth. Management of dental caries should include identification of individual risk for caries progression, as we said here before, and moreover, clinical criteria of visual examination of enamel cavitation, visual identification of shadowing of the enamel or geographic recognition of progression of lesion should be determined before you jump to conclusion and saying, okay, let's restore this tooth. Okay, so let's get deep now to the real deal. Deep caries, excavation, and restoration. So you have three methods to restore. Like imagine you could have lower six and you see occlusal deep caries. You take X-ray, you see caries reaching almost up to bulb and dentin, like you're reaching almost to the inner half of dentin. So you have three line of treatment and pay attention here. First one, complete excavation. So you go, give freezing, use your hand piece, remove everything, and use your hand instrument and to remove everything. You see dentin, discolored, not discolored. You see dentin which is soft, you remove. Okay. Second line of treatment is a stepwise excavation. In this one, caries dentin is partially removed at the first appointment, leaving caries over the bulb with placement of temporary filling. At the second appointment, all remaining dentin, caries dentin is removed and fire restoration is placed. And the third line of treatment, and this is the most commonly used now, and I will tell you why, partial or one-step caries excavation. Here, you remove part of caries dentin, leave the caries part over the bulb, and I think you can know now which part you're gonna leave. And subsequently, place a paste and final restoration. No removal of caries before restoration of primary molar in children aged 3 to 10 also has been reported. And this is a different technique and it's a very weak technique. We're going to discuss it later. Discard this point now. We're going to discuss this point at the end of the article. Evidence from multiple studies showed that frequency of pulp exposure in primary and permanent teeth is significantly reduced when using incomplete caries excavation compared to complete excavation in teeth with a normal pulp or reverse pulpitis. Meaning here, it's very important information and you should pay attention here. So if I'm giving you a question like speaking about lower six and I'm giving you two options, saying this tooth, providing this tooth has normal pulp or reverse pulpitis, and then I am giving you two options to do complete excavation or partial one-step excavation. So according to this article, according to this conclusion, we should go with partial one-step excavation. Why? Because preserving the pulp vitality is extremely important. Complete excavation, if you insist to remove everything, if you insist to remove even the discolored hard dentin at the floor of the cavity, you may end up entering the pulp chamber, leading you need to do root canal treatment or pulpectomy. So you didn't preserve the pulp vitality of the tooth, which is extremely important as we mentioned before. So here, and then he speak about study, giving numbers. You don't need to know numbers. You can read at your convenience. And then saying like the trial was like comparing between the two-step and one-step. Two-step meaning like you go, put the filling, leave the caries, and then go back after 3 or 6 months to remove it and give permanent restoration. They found no significant difference between both, but they found a significant difference between the complete excavation and one-step excavation. So at the end, conclusion, multiple RCT. RCT here meaning not root canal treatment. Randomized clinical trial and systemic reviews determine that incomplete caries excavation, either partial one-step or two-step, like you enter again, in primary and permanent teeth with normal pulp or reverse pulpitis. So it's like two-step decision. You cannot say, okay, let's do partial pulpotomy. For a tooth, the child is telling you or his parents is telling you he didn't sleep yesterday. You cannot do it for a child telling you like I did take acetaminophen and it's not working. You cannot do it for a child telling you, okay, this was swollen before and now the swelling is gone. You cannot do it if you see pus is coming. You cannot do it of patient telling you or his parent telling you the child is feeling bad taste in his mouth, meaning like there's pus coming. So you should pay attention to these details. It's extremely important. It's not about just doing the pulpotomy. You should do verification in two steps. First step, the clinical signs and symptoms. Second step, you do it in a good way, and then you should do very well sealed restoration at the end. Okay, so this is a conclusion here for this one, and it's done. Okay, so there's some restoration called resin infiltration. Resin infiltration is like simply to be said, is a composite without a filler. That's it. It's a composite without a filler. This is to be used primarily to arrest the progression of non-cavitated interproximal lesion, and there is one more use for this resin infiltration gonna be mentioned later. But the main use for it, if you see in X-ray and you see there is radiolucency in the marginal ridge, and it's not cavitated. When you go clinically, there is no breakage happening for the marginal ridge, so this is indicated for resin infiltration, and this is indicated for anterior teeth or posterior teeth, as long as the radiolucency is not extending into dentin. Like if radiolucency is reaching up to dentine enamel junction, there is some like controversy here about like whether you go resin infiltrate or do full restoration. But there is article we're gonna speak about later, like saying like clinically, if you see this, 30% is only cavitated. So resin infiltration here is very beneficial for this case and indicated for this case. There is one more thing, like here, are more effective in reducing the geographic progression of early or incipient proximal lesion on primary molars than preventive measures alone over 24-month period. Meaning, what is the preventive measures? Preventive measures, like you decide this patient is high risk, so you're gonna make X-ray for him frequently. You're gonna give him professional fluoride application. You're gonna give him fluoridated toothpaste, and resin infiltration for this kid for this situation is extremely important and giving more favorable prognosis. And then he's giving you the RCT that was done to explain more about this. And then to wrap it up, resin infiltration is indicated as adjunctive to preventive measures, meaning you cannot say, okay, this patient has high caries risk. Oh, I would just give him fluoride application and then give resin infiltration without reinforcing the toothbrushing, without reinforcing the flossing. No, this will not be working. It should be used above preventive measures. Above preventive measures. It's not to be used alone and saying, yo, okay, it didn't work. No, it should be used again. And there is the other why I'm smiling because you have some question about this one. It can be used for non-cavitated interproximal carious lesion to reduce lesion progression and for white spot lesion to improve their clinical appearance. I'll give you a scenario. Like imagine a patient, you did ortho treatment for him. And you know, ortho treatment, you do brackets here, and you move the bracket. Patient come after 1 week telling you, oh, doctor, you know, my teeth is, it's nice, I cannot see a cavity, but I don't like it. It's chalky white. And this makes sense because you do the composite to adhere the bracket over the tooth for a long time, and it was like covered for a long time. So you have white spots, which is not cavitated. So in this area, resin infiltration is extremely beneficial for this tooth. You don't need to drill it. You just do resin infiltration for this one. It will be very beneficial for him. Okay, so management of dentinal caries should include identification of individual risk for caries progression. As we said before, this is the same story as previous article. It's a story and he's adding more. We're gonna keep it again and again because like when you hear more, it dig deep inside your mind. Decision for when to restore caries lesion should include at least clinical criteria of visual detection of enamel cavitation, visual identification of shadowing of the enamel or geographic recognition of progression of lesion. Okay, so this is the three way we speak about. So he's explaining about them again, saying the complete excavation and stuff like this. We speak about this before, and saying like the stepwise or one step is more frequently used now. Then we're gonna speak about dental amalgam. Amalgam, I don't need to speak about amalgam. You know all about amalgam. Amalgam can be used for kids. I know there is some speculation about amalgam for kids, but to wrap it up, ADA immediately reaffirmed that amalgam is a durable, safe, and effective restorative option, and that the FDA's recommendation didn't cite any new scientific evidence. So to wrap it up, like in Europe, I know they ban amalgam for the kids. No, FDA didn't ban amalgam for kids as long as he didn't show any signs of hypersensitivity for mercury or previous instance of sensitivity to mercury. You can use amalgam for this kid to restore his teeth, maybe after pulpotomy or stuff like this. It can be done. So you don't need to worry about this one. Okay. So and then he speaks about now class 1 and class 2 and success rate. So class 1 amalgam restoration in primary teeth has 85 to 96% success rate up to 7 years with average annual failure rate of 3.2, which means it's amazing. So it can be used for class 1 amalgam restoration. And for permanent teeth, it has almost the same up to 7 years. Okay. For class 2, and there is a very important guideline you should consider here. If your class 2 is exceeding proximal line angle, so you cannot use amalgam for this one. So again, to be very clear about this one, if a class 2 is involving the buccal or lingual surface, you cannot use amalgam or composite for this one to be restored. For this purpose, you're gonna use C crown, and I'm going to prove this later in the same article. So it's very critical to understand here the restoration of a choice after papotomy, bulbectomy, or if you have class 2 with including extend beyond the line angle, is a stat C crown. It's not amalgam, it's not composite. Okay, but anyway, class 2 restoration in permanent teeth or the primary teeth with amalgam has been proven to be has a success rate up to after 7 years up to 92 to 94%. So it's amazing for sure. Okay, so recommendation to wrap it up: dental amalgam may be used to restore class 1 and class 2 cavity in primary and permanent teeth, and success rate is amazing here. So it's recommended to use amalgam, and as we stated, speculation about amalgam is not to be considered here. FDA approve it as long as the patient has no allergy for this one. And then we speak about composite. Composite, as we all know, I don't need to speak about it. It's resin reinforced with fillers, and then can be used for this one. And then he speak about the so it's the same like amalgam. He speak about like the success rate and can be used. And then he give you the criteria here. He give you RCT explaining about it, and the guideline here: resin-based composite can be used as a class 1 and class 2 restoration in primary and permanent teeth. It has a success rate which is extremely high, 81% up to 36 months, and it has a good success rate, so you don't need to care about it. It's a very good option. And then we're gonna speak about glass ionomer cement. Glass ionomer cement can be used to restore it, but like it has lower for sure success rate than amalgam and composite because it's just cement, but it can be used. And then he's going to give you the numbers for this one. For glass ionomer cement, one RCT showed the overall median time for treatment to failure of conventional glass ionomer restored primary teeth was 1.2 years, so it's 1 year. So I don't think this is a good recommendation to be used. Conventional glass ionomer has not been recommended for class 2 restoration. So for class 1, it's not very good. For class 2, they didn't even try to use it, okay? And then there is resin modified glass ionomer. They did meta-analysis about it. They have more success rate than the glass ionomer which is used conventionally. But he said like conditioning dentin improves success rate of resin modified glass ionomer, and the cavo surface beveling lead to high marginal failure resin modified glass ionomer and is not recommended. So you know what some dentists try to do, like he go to the margin for the enamel and he do a bevel, thinking like will give him good bonding between resin modified glass ionomer and the enamel. This is correct for composite, but this is not correct for resin modified glass ionomer. As you can see here, the RCT again is randomized clinical trial, showed this is increasing the failure rate, marginal failure, so this is not to be used. With regard to permanent teeth, a meta-analysis review reported significantly fewer carious lesions on a single surface glass ionomer restoration in permanent teeth after 6 years as compared to restoration with amalgam. And this is the catch point for resin modified glass ionomer or glass ionomer. It releases fluoride, but again it should be used for one surface. For class 2 restoration and permanent teeth, one RCT showed unacceptable high failure rates of conventional glass ionomer, irrespective of cavity size. Even if it's small, it's not recommended. Okay, and then we're gonna speak about SDF. SDF is a magic. I use it. It's amazing. It's amazing. We're gonna speak about it later in different articles. But our SDF is amazing in arresting caries. It has dual action, silver and fluoride. But we're not gonna speak about it now. We're just gonna wrap it up here for the resin modified glass ionomer. As we said, it can be used, but it cannot be used for class 2. And we don't do bevel, as bevel increase the risk of marginal failure. Okay, glass ionomer may be used for class 1 restoration in primary teeth. Resin modified glass ionomer may be used for class 1 restoration, and expert opinion for class 2 restoration in primary teeth. Evidence is insufficient to support the use of conventional or resin modified glass ionomer as long-term material in permanent teeth. So for primary, yeah, you can use it, but for permanent, you cannot use it. Compomiers, this is like a mix between composite and glass ionomer again. Nothing here to be mentioned. Like further research examining should be done to speak about it. So just discard this one. And then we're gonna speak about preforming metal crown or PMC or Stasi crown. BMC or SASI crown have been indicated for the restoration of primary and permanent teeth with extensive caries, cervical decalcification, or developmental defect, hypoplasia, hypocalcification, when failure of other available restorative material is likely. When interproximal caries extending beyond line angle. You remember I told you this before. Patient with bruxism, if you give him class 2 composite, it will not be working because he will break it very soon. Following pulpotomy or pulpectomy for restoring a primary tooth that is to be used as an abutment for a space maintainer for the intermediate restoration of fractured tooth and for definitive restoration for high caries risk. Okay, so again, it's extremely important. Give me your full attention here. SASI crown is the restoration to be used after any pulpotomy, any pulpectomy. Can be used for primary tooth, can be used for permanent tooth. Oh, 1 minute here. You're saying can be used for permanent tooth? Are you sure? Yes, think about this. If I'm speaking about um 10 years old and he has lower 6, you did RST for this one. After RST, what is the next step? You should do crown for this tooth to make sure it's has a good success rate after 5 years. But for 10 years old, we cannot do crown. We cannot take impression for this one, make a crown because the mandible is still growing, blah blah blah. So what you should be done now? You should give him amalgam or give him composite, which will be broken soon because like RCT for lower 6, it has a huge cavity. No, in this case, you use SASI crown. So this is the way. Our question is clearly mentioned the patient has a bruxism, or the question saying this class 2 is extending beyond the line angle. And just for your knowledge, if a class 2 extending beyond line angle, this patient, if it's a permanent tooth in an adult, it's indicated for inlay or onlay. So it's not indicated for filling, just for your knowledge. But like we can discuss this later also. But again, and then intermediate restoration of a fractured tooth. This part is extremely important. I will not start speaking about it unless I know you have all the information you need to get from this part. Like if a question is saying like the tooth is painful when you bite over it, so you suspect cracked tooth syndrome. Cracked tooth syndrome means like there is a crack running inside the tooth. Crack is very difficult to be clinically visual. You cannot see it. You need to do translamination. It's very difficult to see a crack. So you cannot jump to conclusion saying, okay, let's do a full metal crown or do BFM crown or zirconia crown here. It is very aggressive for the patient. So it's intermediate restoration. So you give the patient a C crown, you give him provisional crown and let him go home, come back after 2 weeks. If he come back saying, oh man, this is amazing, pain is gone, everything is good. So now we tell him, okay, so you have a crack in this tooth, we should give you a good restoration and then cap it with a crown, okay? This is very important. I should mention this again and again because this part is like giving you a lot of answer for some question. I know it's sweet for you, okay? And then he's speaking about studies showing like this is have average failure rate is less than the using for composite or glass ionomer or amalgam for class 2 restoration, especially the one extending beyond the line angle, okay? And then he's going to speak about, I know it's a little laggy, okay. And then we're gonna speak about wrap it up then in a chart, so it will be obvious for you which restoration is to be used for which indication. So for class 1, we can use amalgam, we can use composite, we can use glass ionomer, so it's recommended to be used. But for class 2, you can see there is evidence against which glioblastoma, rhizomatophaga glioblastoma, and strong evidence for amalgam and composite. And there is, you can see expert opinion. Expert opinion means what? Meaning, like, you cannot do study, like, it's non-ethical. Think about it. Like, you have two children coming to your office. Okay, so I will do some experiment over you. I will give you composite. I will give him rhizomatophaga swimmer, and then let's see what's going to happen for you after 36 months or 18 months. And the other one was the bad restoration, ending up losing his tooth and then going for more complication about the eruption of permanent teeth. So expert opinion meaning, like, there is no RCT giving you solid evidence about the numbers and everything, but the experienced dentist saying, okay, we use this one, we use a solution for more than one patient and it's working. But again, it's not a recommendation. It cannot be saying, okay, this is the guideline. It's just expert opinion. So again, for a style C crown, we say we're gonna use a style C crown if apotemy, apectomy, or class 2 extending into the line angle, going buccal or lingual. And this for primary teeth. For primary teeth is the same criteria, almost the same. So strong evidence for amalgam composite for class 1. For amalgam, strong evidence for class 2 for amalgam. So you see here evidence in favor. So if the question asking about class 2 restoration in posterior teeth and you have amalgam or composite, you're gonna lean more to amalgam. And glioblastoma evidence against. So it's 3 steps. For class 2, strong evidence with amalgam, evidence in favor of composite, and glioblastoma evidence against. So here, like, I know you may think like this is like not very important. No, it's important. When you have the question and you just have this option, you should know which to choose what. Okay, and then we're gonna speak about the option I told you about. It's honestly, it's a weird question. It's a weird technique, but like I know some dentists using this one and they are super happy with it. So it was introduced with a dentist called Hal. So he named it after him, and he called it Hal technique. The Hal technique calls for cementation of a C crown over a caries affected primary molar without local anesthesia, without caries removal, without tooth preparation. Yes, you heard it correctly, and you can read it after me here. So Hal saying, okay, so we all know as dentists, like, caries is coming from bacteria, so it's a plaque-induced disease. So if you have caries lesion, and this caries lesion inducing a cavity, this cavity accumulating more food, more bacteria, plaque is here, working more, caries is progressing more. So he think, okay, so if we cover this tooth with plastic crown, with nothing, with no anesthesia, with no tooth preparation, so we are making sure this is like sterile environment, away from bacteria, away from plaque, so the caries will not progress more. And honestly, this is a weird technique, but like he did some study about it, and the success rate for it, it was amazing. Success rate is almost the same as if you do um pulpotomy and anesthesia crown, which is honestly weird, honestly, but this is what is you can see here. Therefore, use of anesthesia crown is indicated for high-risk children with large or multi-surface cavitated or non-cavitated lesion on a primary molar, especially when children require advanced behavior guidance technique, including a general anesthesia for provisional of restorative dental care. Okay? So, like, this hot technique is, I'm not telling you to do this in your office. I'm just telling you to know this one. If you for any reason see this option, you saw, okay, so a hot technique, I know what this hot technique is here. Okay, and then there is one last important point here. So some children they don't like sassy crown. Either you telling his dad or telling him, okay boy, this will stay for just 2 or 3 years till your permanent tooth is here. So some kids like are suffering from bullying in the school, so he's not happy with this. So now there is some zirconia crown that can be used instead of sassy crown. But for zirconia crown, there is more circumferential tooth reduction is needed for proper fitting and placement of the zirconia crown compared to sassy crown. And for proper retention, the minimum abutment height is to be 2 millimeters. So in sassy crown, you're just reducing 1 millimeter, 1.5. For zirconia crown, this is not, because like zirconia is brittle, so it should have minimum of 2 millimeters thickness. So it's more reduction circumferential and more reduction in the occlusal surface. The indication for preformed static crown, which is zirconia, are generally the same of those for prefabricated C crown but with a consideration of aesthetics. Clinical parameters between zirconia crowns and SLC crown are similar. So it's similar, except for retention and gingival health. SLC crown has comparatively better retention, and zirconia crowns have relatively better gingival health. Zirconia crowns have relatively better gingival health. Please pay attention for this information. Evidence is limited on the use of zirconia crown as a static crown for primary posterior teeth. When a SLC crown would otherwise be indicated, zirconia crown may be considered in lieu of SLC crown due to aesthetic consideration. In lieu, like in replacement for SLC crown, if you have aesthetic consideration, like if the question mentioned patient is complaining about pulling in the school, stuff like this. Okay. And then finally, anterior aesthetic restoration in primary teeth. There is more evidence about this zirconia crown to be restored in the anterior teeth, especially in class 3. Interproximal in primary incisors can be used, but again, you should know the limitation of the tooth. Like this tooth, if like a child is 6 years old, 6 years old, this tooth will, like if speaking about upper anteriors, like primary A, if 6 years old, so you can just use resin modifier, you can use composite, but like if he's too young, if it's like 4 years old and there's a huge destruction and huge cavities, a huge cavity affecting the upper anterior, so you should go for this one. But again, so it's clinical judgment. You should use your judgment about this tooth. It's not about like we're gonna use this one for this one, okay? So this is again the wrap up for this part about the restoration. You should know, let's wrap it up with together. Okay, so first of all, you should know the restoration needed to be done, if you need to be restored and not to be restored, and then you should think about it in perspective for this patient about the high risk or low risk or moderate risk, and this is a different topic we're going to speak about later, and this restoration to be used for him in conjunction with other oral health instruction that need to be given, flossing, toothbrushing, stuff like this. So restoration is not to be used to replace the oral hygiene instruction. And then you're gonna think about the tooth itself, the clinical criteria about the tooth. It's normal pulp, it's reversible pulpitis or irreversible pulpitis, so it's different treatment line of treatment indicated for everyone, for every tooth. And then you're gonna think about class 1, class 2, and then we speak about the recommendation for class 1 and class 2, and resin infiltration when to be used. SLC crown should be used after each pulpotomy, each pulpectomy. If it's class 2 extending beyond the line angle, it should be used a SLC crown, and then zirconia crown should be used if the pulling history is present. And the privilege of zirconia crown over the SLC crown, it has better gingival health. It has better gingival health. And that's it for this articles. I hope that was beneficial for you. I think this article should be studied with the other articles. The first article we speak about the trauma and avulsion and stuff like this, because this is one topic. You should be familiar with everything in this one. Feel free to watch the video again, share the video with your friends, give me your feedback, and see you later. Bye.